And now, ladies and gentlemen, to wrap up our afternoon session, we bring together industry leaders and policy experts for a dynamic discussions on how innovation can save time, reduce costs, and save lives. The session entitled Malaysia's Healthcare Challenges: Can Innovation Save Time, Save Costs, and Save Lives? Of course, our moderator will be presented by Dr. Peter Kim from ICVIA, and joining Dr. Peter Kim, we have an esteemed panelist. Ladies and gentlemen, let us welcome them, Mr. Ambuj Mudgal from AstraZeneca, Professor Dr. Sazli Shazlan Kasim from University Technology Mara, and Dr. Koo Soo Beng from Stratofacian, Australia. Ladies and gentlemen, please join me in welcoming our moderator and panelists to the stage.
Thank you, and welcome to the session today. So let me start by firstly thanking the Moranti team for organizing this session. I think it's going to be a very exciting discussion today, and let's hope we are all open-minded today to talk about the healthcare challenges and also where innovation can step in. So let me start with a few facts first, right? So if you think about Malaysia healthcare, I think we are probably we have one of the better healthcare globally. If you just take a phone, just do a quick Google search and look for Malaysia healthcare ranking, you still see Malaysia having very decent standing across many different pillars, right? We've been, I think, one of the best countries for healthcare, medical tourism. There are a couple of other aspects where we are outstanding compared to the others. But we all know that we are still far away from perfection. There are clear challenges that we can see today and also ahead of us. And there are a couple of statistics that I want to talk about before we start the session today, right? So firstly, if we think about our Malaysia healthcare, our healthcare spending stands at around 4.6% of our GDP. And that's below the 6% of WHO's expectation for what good healthcare spending should look like. If you look at the government spending, it accounts for roughly about 50% of the overall healthcare spending. And that is growing at about 7 to 8%, which is better than GDP, which is good. But it lags significantly behind our medical inflation, which was recorded at about 15% as of last year. And this shows that while the growing expenditure is a good sign, it may be addressing the inflation over addressing productivity. The third thing, because I mentioned productivity, right, it's also a key concern. So if you look at the OECD data, the healthcare labor inputs may rise, but it does not always justify the matching of productivity gains. And this could be another issue that we see in Malaysia, as healthcare practitioners not often always spend their time in medical, but they also spend quite a fair amount of time in administrative tasks, which could lead to productivity challenges. Two more. One is aging population, which is going to hit our healthcare even harder in the next couple of years. So we think the aging population will hit about 15%, which means about 15% of population will be over 60 by 2030, and it will get worse towards about 25% in 2050. And this will lead to higher NCDs, incidence and prevalence like cardio, diabetes, cancer, and many others, right? And last bit I want to talk about, which is important, and this is where I would like our panelists to provide inputs as well, which is access. So today, for those that are living in Kuala Lumpur or in the major cities, we have good access to clinics or best tertiary care centers or institutes. But when you get out of the big cities into the rural areas, this becomes a whole different story. So the question often becomes, how do we equate healthcare services to those even in the rural areas? And I think this is where I believe that this discussion is really timely, because if you think about today, we often talk about innovation, and just now in a couple of talks as well, we started seeing a lot of healthcare innovations. And the question is, if you think about it from a Malaysian's context, can innovation offer this solution to save time, save costs, and save lives? So I hope we can discuss a lot more on that as part of this today. So with that, just a quick introduction. My name is Peter Kim. I'm a consulting partner for IQVIA. We are one of the leading companies when it comes to healthcare and artificial intelligence. And together with me are three exceptional individuals. who will bring different lenses when it comes to healthcare topics. So maybe let me start with the person sitting right to me. Mr. Ambuch is representing the AstraZeneca, and he will bring the pharmaceutical leadership. So Mr. Ambuch's specialty lies in digital technology and AI, and he has a lot of passion and have led a lot of partnerships, especially between private and public when it comes to diagnostics and screening. The second expert will be Dr. Ko. He's currently a director of PMO for innovations and senior associate in Stratovation. He holds certification in design for Six Sigma Belt and is specialized in innovation management. And our last panelist will be Professor Dr. Sasley, a cardiologist, health economist, and a businessman. And we'd like to hear, and we'll probably want to hear more from you on what you've seen, what you've done, and how you view the challenges, framing solutions, and barriers going forward. So with that, maybe let's start with some very simple questions first. Maybe let's just kind of open up. So I think this question resonates quite well because everywhere I go, when I talk to my clients, this is the question I get, is where does innovation come into solving for healthcare problems in Malaysia? And often my answer has always been about access and affordability, which rhymes with the biggest challenges that we see in Malaysia and also in Southeast Asian region. But I would like to hear from each of the panelists here today, what are some best opportunities that Malaysia can see in terms of where innovation can come and either make it more efficient, affordable, or life-saving? So maybe let's start with Mr. Ambuch.
Sure. Thanks for the opportunity. Good afternoon, everyone. So I think what is the biggest opportunity? Let's lead by examples, right? So we've done this before. Malaysia has done this before, right? When COVID happened, there was a certain urgency around making sure that public healthcare is taken care of. So the My Sejahtera app was brought up, right? It now has over 30 million users. The app was not sort of abandoned after COVID. It was built on. At the same time, there was Telemedicine Act, which was amended, which now means Malaysia leads with about 70% healthcare providers offering telehealth services as compared to 40 to 50%, in ASEAN, as an example. We at AstraZeneca, now taking a slightly commercial pharmaceutical angle, we at AstraZeneca, being one of the largest pharma companies, our strategy or philosophy around digital and AI has been that we would use the best available opportunities to make diagnosis early, as well as pair it up with optimized healthcare, right? So the examples we have seen during COVID time around policy, participation from pharma companies, around digital, expanding reach, is something we've done before. It has happened. And now it is the time that we can replicate that. Learning from that, we can replicate it. So for me, that's the biggest opportunity. We do see the building blocks of it. We need the right kind of support across various functionaries to make it happen. Yeah.
Maybe over to you, Dr. Ko.
Yeah, thank you. First, thank you, Amranti, for inviting me to this forum. And secondly, I would like to disclaim myself. Everything that I'm going to speak about in this forum are entirely my own and not representing my company. Right. So I think going back to the innovation, Malaysia, to be honest with you, we are very creative, we are very innovative. Just take a look at traffic lights when you stop. The motorcyclist doesn't need to be stopping. They find a creative way of circumnavigating around. So that is what we are. It's part and parcel of the creativity, right, that we have. So do you know that in 2018, this is public domain information as well, we already innovated AI-enabled stethoscope, right? So it was launched, right? If you just check the Star newspaper. So in short, innovation is everywhere in Malaysia. So what's the problem? Well, the only thing is actually, this is learning from, if you go to fast food chain, Do you buy combo meal or you buy the piece meal? Most of you will buy combo meal because you know it's cheaper, better, it's all complete. Now, putting back this to innovation in healthcare, we do have innovation, but it's pockets of excellence here and there. It's not cohesive, it's not integrated, it's fragmented. So that is where you cannot have something that is going to move very fast in one innovation area, but on the other side, it's very slow. An example, you can go to a hospital which has very good, efficient health screening, checkup, everything that can be done in less than an hour, but you wait for 3 hours to get the billing done. So that is where things are. It's fragmented, and in short, we are innovative, we are creative. You don't get disheartened that we are not there. We are similar to the world players. All right? So I'll just leave it here at this point in time because we need to achieve it through a systematic approach rather than ad hoc piecemeal approach. Thank you.
That's a great point. I think we'll touch on some of this maybe in the later questions. But maybe let me move to Professor Susli for your initial thoughts.
Thanks, Peter. I'm not a businessman. I'm an academician. Used to be a hospital director, built a hospital, cardiac unit, those kind of things. So Malaysia in itself is a very innovative. I mean, like Malaysia Boleh is our tagline, right? And our healthcare innovated itself in the, I think in the 80s and 90s when we started the private hospitals. And even prior to that, we had our private clinics coming out of, spin off from the Klinik Kesihatan. And there's not too many countries around the world that have a dual healthcare system. Fully public with universal access, very cheap, very accessible, 1 ringgit for general registration, 2 ringgit or 5 ringgit to see a specialist, albeit the long waiting time. Or if you have a bit more capability, then you will be able to access private healthcare with insurance or pay out of pocket. And I think the statistic is still with 30% of patients paying out of pocket and 70% of them utilizing government services. That's number one. So we start off innovating access to healthcare at a very early stage, recognizing that our country, at that particular point, being an agro-based country, transitioning into heavy industry, would not be able to afford the level of healthcare like a first world country, even to our neighbor like Singapore, because healthcare is expensive. So then it comes to how do you deliver healthcare? Who gets the best healthcare? Who do you have to cut short your healthcare? And these are not things you want to discuss in public because it's a very dirty word. Very, very, that's humanitarian-like, issues. And to be honest, in treating a patient, we don't make that decision. But when you're looking at healthcare in general for the whole country, you cannot deliver the best level care to everyone. I give you an example. I'm a cardiologist. I'm a heart doctor. You were to have a heart attack, the best treatment for you to get is coming to see me as a specialist. I'll operate on your heart straight away, open up the block, and you can go home in 2 or 3 days' time. Your heart function is preserved. Your risk of developing heart failure is almost zero. You live a normal life. Remember, you had a heart attack. A heart attack is normally what we call a non-communicable disease, a lifestyle disease, something that you chose for the past 40 years of your life. I'm not trying to blame anyone. Our roti canai, teh tarik, nasi lemak is just too good, okay? No blames, no blaming here. But that's just the fact. We're in Malaysia, we're too innovative, we kill ourselves for fun. Anyway, but that's the best level of treatment. Can all of you access that level of treatment? You can't. Some can. Some don't. Some are lucky enough to access that treatment when the scenario is at the right time, at the right place. If you were to come to my center during the daytime, you will be able to access all the beautiful treatment. But after hours, due to manpower shortages, staff shifts and so on, you won't be able to. You'll have to go to a private hospital to get there. When you go to a government center, you get the next level, the next best level care, thrombolysis, which is a blood diluting medicine. So in delivering equitable healthcare, we also have to be selective without jeopardizing the need of the nation. So the approach has to be quite balanced. And I think it's an important note in terms of innovation, because innovation, yes, in the long run, it saves more money, But as we were discussing before we entered this panel, what Dr. Koh said, it's real innovation, not invention. I think you should touch a bit more on that.
You want to maybe touch on that?
Yeah, okay. There was a discussion, right? Innovation versus invention. So I'm a bit biased because I actually be part of the committee who develops the ISO standard called ISO 56001. If you Google that, it's Innovation Management Systems. So innovation will deliver 10x return in value. Either 10x productivity improvement, 10x cost savings, 10x maybe social value creation, and so on. When you have the 10x, definitely, if you have something that cannot scale 10x, it means you only have invention. So the difference between invention and innovation is you invented something new, right? So you may have a new way of detecting cancer. You invented it. But how reliable it is for you to scale, right? If you cannot scale, then you ended up with you invested a lot of money, but you cannot have the return on investment. So the moment you can scale, and usually it's in terms of manufacturing, in terms of software, in terms of adoption, those are the things that we qualify it as innovation. And I'm proud to say that today we actually have a secret recipe called ISO 56001, Innovation Management Systems, and that's where it was launched a year ago, right? And many countries already use this framework. You can go from 56,000 to 56,010, and 11, 12, 13 is still on development. So standard systems, and that's where invention always give you sometimes works, sometimes don't work. The return value is not consistent. So if you want to go for the pro, go for those innovation, right? If you go for amateur, I can be a football player scoring goal as well. After playing 10 years, I scored 2 goals. But the pro will be this season, 50 goals, they will score 50 goals by design, not by serendipity. So that is where I'll stop at. Thank you.
I'm sure we'll touch more on that when we talk more about the current state, maybe later on. But maybe let me get to the topic first, right? So, we're talking about saving time, saving costs, and saving lives. So maybe let's start with saving time. So if we think about saving time, we live in a resource-constrained environment. So it's not that we have everything unlimited, right? So we need to be really careful about how the resources are being used. But often we see a lot of inefficiencies that often manifest as either delay in process, which leads to delay in diagnostics, delay in time to get appropriate treatment, right? So if you think about it from that point of view, maybe the question for you, Dr. Professor Sazli, is if you think about patient journey and a patient care, right? Where do you see this sort of bottlenecks happening, and where do you see innovation stepping in to solve for this?
So oftentimes we're talking about sick people coming to hospital, but innovation should really be targeted toward preventing them from coming to hospital. When you come to the hospital, it's too late already. Because if you're in the emergency department, like 70% of the patients there waiting for 3 hours or longer to see a doctor. Usually you spend at least a minimum of 6 hours if you're in the green or yellow zone, a lot shorter if you're in the red zone. The red zone means you're critically ill. So you really need to think. If you're thinking about the processes and bottlenecks, it spans from the very moment you leave home to visit community care, GP services, accessing the ancillary services associated with it. And the easiest one is pharmacy, readily accessible. But what about everything else? Physiotherapists, occupational therapists, speech and language, things that are needed for one patient to be wholesome, being looked after quite close to their home. And this is why listening to this iCure solution, it kind of like makes sense. We're almost there. We have good social network, clinic kesihatan, public health services within the community. But unfortunately, it's a free service. The carrot is not there. So therefore, you're working 9 to 5, and what happens after 5? What drives you to be able to provide is 5-star level services? Nothing. So innovation can step in those places, into those gaps, seeing where the bottlenecks are occurring in the first place, but addressing solution that is not only sustainable, but also profitable, but it also makes sense to patient before they have to seek care, which is at the level of the hospital.
So maybe just a follow-up on that, because if I think about Malaysia's healthcare, like especially within the primary care settings, right? If you go to the clinics, there's a huge queue. Just if you have fever, just to see a doctor, the waiting time can be anywhere between 3 to 4 hours. I think that's the kind of problem that we're seeing today in the public sector, the overcrowding, right? So where do you see the innovation?
So it doesn't really take innovation because it's just answering a simple solution. Can I make this patient journey a lot shorter? And that's process automation. You can register at home on your mobile app. You can do that. You arrive, you take your vital signs, low-level clerical staff with a bit of medical input can do that for you. Time to see the doctor. The doctors are the expensive cost. Maybe a specialist nurse is also an expensive cost. Okay, you want to spend some time. If you can fast track and increase training of specialist-led services, then you'll reduce the waiting time to be seen by those doctors. But sometimes patients goes to this clinic to refill their medication for routine follow-up, whereas those kind of input could also be captured without coming to the hospital, for example, without going to the clinic. The wearables, the nudges, the inputs that they can give on either WhatsApp messaging, those are the things that need to be innovated but placed into the system of care and captured and auditable as well, so that patients are safe and healthcare becomes more efficient. After they see the doctor, how long do they have to wait for the medication? About another 3 hours. Why? Because medication have to be ordered. Sometimes we order wrong, and sometimes to correct a wrong order takes about another hour. Okay, once it's ordered, then the pharmacists have to prepare the medication. That takes another hour. While waiting for that, the patients have to go and pay for the medication, and the queue for paying is also very, very long. So why not do away with all those things? Why not just tell the patient to go home, post out the medication to them? That's what we tried today in UITM. Some useful, some challenges, because patients still needs to be educated in terms of how to take the medicine and so on and so forth. But all these little challenges are actually very solvable. It's just process automation.
So yeah, maybe the question for you, right, Dr. Koh, maybe just follow on that. So if you think about other markets or other regions, especially those markets that are more mature, so let's say like in Australia, Korea, a couple of other examples, right? Where do you see this sort of process being implemented to kind of speed up this process that maybe we're not seeing in Malaysia yet?
Okay, that's a good one. Actually, I was going to piggyback on Prof. Answer, right? So when you have queue, you have people waiting time. You need to define the problem. It may means that the capacity problem, right? The capacity of the hospital, the staff, and everything else is not able to cope to serve that patient group. So how do you do? So in innovation, the first thing is you need to define what problem are you solving. Why are you doing what you're doing? So if you want to reduce the number of patients or reduce the queuing time, so that is one thing which Prof already mentioned, which means that you really push away those people on the routine follow-up, don't have that category of those who may not necessarily need urgent help in the hospital. Push them aside. Can digital help? Digital health helps, or maybe using telemedicine. That's one group, you push it away. The second group is you improve the operational efficiency of your hospital. And thirdly, well, that is actually something that the speakers already alluded to earlier. Rather than sick care, preventive care, right? So now coming back to other Western world, right? Because I can only speak for US, UK, Europe, and Australia, right? So the way they do it is very simple. It's exactly like what I just described to you. Do this patient really needs to go back to hospital? And they track the hospital bed, they track the number of hours you spend in hospital. So whatever we want to do with AI and all those type of wonderful things we think we want to do, the first thing is data. If you never collect the data, you're not able to justify the 10x and so on and so forth. Therefore, you go into a vicious cycle again, right, of trying to do something. So it's, in a way, you need to approach it in a systemic way. So another thing that comes back to here is, a lot of times we think innovation, we only think of one stakeholder, the patient. To be honest with you, for those people doing design thinking, you always say, oh, what is a persona? You have a doctor as well. the specialist. You have the patient, which is that maybe if you take, for example, if you are the diabetic patient, then you are just one. What about the caregiver? What about the payer who is paying for all this solution? So if you really map this out, then you actually will know the answer yourself. And in the Western world, I mean, there's one example. I don't disclose the client's information, but what they have done is actually, it's a journey. If you are a diabetic patient, you and your specialist doctor has to decide what is the prognosis, how best to manage, and you committed to the plan. And can technology assist you? Because at that time, if you put a roadmap, okay, assuming I'm the diabetic patient, then my doctor say, okay, every month you have to come and see me. So if I see, you have to commit to the plan to manage the NCD. So if I want to commit to this, and I start to realize that I'm living away from the hospital, like 300 kilometers away, every 2 weeks I have to travel to see you? No way, right? So no way, what do? You look for alternative. Can telemedicine help? Right? You interlace with that. So now, a simple thing like this, you see that you actually have this approach of co-managing the journey. When you have that, then that's where you will be able to gain trust, and also the medical doctors, specialists, they are not going to risk their license or practice just to put a big bet on your solution. So that is something that perhaps I think AstraZeneca may have a better perspective on that. So that's how we manage. You need to really see the big picture and manage it in a holistic manner. Then that's what we use the word innovation. Otherwise, it becomes an invention.
And what is it that typically multinational companies do? You work together as part of partnership to solve for these sort of problems.
Right, thanks for the question, and I agree with the panelist here. I'll just perhaps provide another example, right, on a setting where time to diagnosis can actually save lives, right? So if you look into oncology, right, lung cancer in particular, almost 90% of lung cancers get detected at late stages 3 or 4, right? Lung cancers detected at early stages 1 and 2 have a much higher chances of survival with the right therapy, right? So if someone gets detected early, they have a 12x chance of survival as compared to someone who gets detected at stage 4. Now, if you take that problem statement and think about how much is the time to diagnosis important, it becomes very important, right? Because the stage shift, as you call it, happens progressively. So AstraZeneca sort of recognized this problem, and we worked with a startup to put in place a AI-enabled chest X-ray solution, which works at a community healthcare setting, at a clinic setting, and using X-rays, which is anyways a modality which is very well understood. It is low cost. The AI chest X-ray detection works on top of that and identifies suspicious nodules, right? So suddenly we are looking at the cancer screening, which could take months to get done, being done in relatively shorter amount of time. We have piloted this in Malaysia. I'm happy to state we are already working with 7 primary care clinics, 5 tertiary care partners, and the Ministry of Health has announced its intention to increase AI-enabled chest X-ray from 7 to 150 clinics in the near future with our partnership. And that to me underscores, how innovation can save lives by shortening the time to detection, right? I mean, this manifests different ways in different disease settings, but I think, this sort of makes a good point.
No, I think that's perfect. I mean, it's really good to hear that, you guys are doing something about it. Now, I mean, if I understood correctly, typically multinational companies to prioritize the bigger cities, the bigger hospitals, and etc. That's where they typically pilot. So, I mean, going back to the point that I made about, equal access to entire population of Malaysia, what is it that AstraZeneca or multinational companies are doing to get that level of technology innovation into the more rural areas?
No, that's a good point, right? So there are two things, right? Accessibility, affordability, right? How do we solve for that? Because the paying capacity of people in metros is much higher. Hospitals, tertiary care centers are much closer as well. Both of these things are not there in rural settings, right? So extending on the example which I just gave, a typical chest X-ray is around 8 to 10 ringgits, right? The solution I just talked about, the AI-enabled chest X-ray, just adds a few more ringgits on top and provides the service right there at the point of care, which implies that if a primary care clinic is enabled with a simple solution of a chest X-ray, we could actually do early detection for lung cancer as well, right? Similarly, we have piloted a cardiac AI ultrasound in Sarawak, right, which is probably not one of the metro regions here. We've done that, and we have realized that using that, we are able to shorten the time to diagnosis. We are able to make more definitive diagnosis, which implies that a lot of patients who would have been asked to go to a certain hospital hundreds of kilometers away to get definite diagnosis do not have to do that as well, right? So that takes care of, one, the price or cost to the patient to get the diagnosis done, the time and cost the patient has to put in to travel to bigger metros and you know, get treatment, and also the fact that this helps the governments or the payers, public players in question, have to spend less and have more impact, right? So, I mean, I couldn't say it better than, you know, rather than giving these examples, and I hope that made sense.
Great. No, I mean, since you've talked about cost, which is the next question that I wanted to talk about, right? So maybe let me ask a question to Professor Sasli. So, I mean, when we think about cost, we can think about it from two ways. One is the operational cost. So in an environment where we have finite resources, how do we optimize the cost, right? The second part of the cost is cost to the patients, because affordability is a huge concern, like you said. So, you know, how do we think about, you know, managing the cost so the patient can get into access to the most innovative care? So maybe a question to you is, if you know, you as an healthcare economist, right, where do you see the most promising innovation where we can think about reducing the cost without compromising quality in healthcare?
Absolutely. So I think I've touched on this before. You've all been affected by raw 95 pricing. And in fact, you have to use your IC to queue, to charge, and to go back to your car. So you think you're saving money, 6 cents, but you're actually spending more time at the petrol station. So there's always an offset. So cost is very dynamic. So when we talk about cost in terms of healthcare, there's monetary cost, the actual money that you spend. There's time cost, there's productivity cost, there's human cost as well. How do you balance it out? And it all depends on where you're sitting, which table you're sitting. If you're the Minister of Finance, you want to really reduce your spending for healthcare as much as possible, spend the least amount of money to get the most impactful outcome for your population. So how do you do that? Prevention. So if you were to really, and we all understand this, if you were to try and reduce the extremely high cost of tertiary healthcare, hospital care, then you want a healthy population. You want to do your massive X-ray screening, ultrasound screening, blood testing on the whole of the population and repeat it every 3 years so that you know exactly who are the sick people and who are the not so sick people. But you must understand, when you deploy that level of healthcare screening to the population to pick out 1 out of 100 patients who would be sick, you're also applying something to them. In this case, X-ray. In this case, their time to come to the hospital, to the clinic, to do the services itself. And inadvertently, you might be triggering something. These are things, unintended consequences. And this is something that we are not aware of, or maybe we are aware, but we're keeping quiet. That could also happen. I'll give you an example. Smartwatches. Huawei, Apple, Samsung, Fitbits, all able to detect ECG. Very good for the patients if they are worried about their health in terms of, do I have an abnormal heart rate? Could I have atrial fibrillation? Atrial fibrillation is a heart condition where your heart is abnormal, and if you have it, your risk of stroke is a bit higher. So if you go on a blood thinner, which is cost, then you reduce your risk of stroke. It's only accurate 30% of the time. 70% of the patients that comes to see me with palpitations saying they have an ECG showing atrial fibrillation and so forth actually have normal heart rhythm. So it also adds cost to them to go to the hospital. It adds anxiety cost. Now they cannot sleep at night thinking, oh, I'm going to die sooner. It adds legal cost. They're engaging in a lawyer. Let's draw up a will. It's all downstream. So now the question is, how do you balance all of that? We won't know until we try. I think population health, preventing and maintaining a healthy population is still the best way to do it, especially for NCD and cancer screening. I think that's where a huge amount of investment have to be put at. But when you say those kind of things, somebody will put up their hands, what about rare diseases? What about sickle cell? What about all these other things? Am I not a human being? So that's human cost as well. So we have to make decision. So the decision can be made based on multiple levels. How much money do I have? How do I empathize with those kind of population? Was I affected by my family, by my immediate partner, by lobbyist group? All those things comes into play in terms of making that decision. And that's why you have the current state that we have right now.
No, I think that's definitely something like a blue book that we've seen in some of the more Western markets, emerging markets. And I'm sure, Dr. Koh, you can maybe talk more about it. But maybe, Dr. Koh, question for you is, if you just think about it from that perspective, if you look at all these Western markets or the mature Asian markets like Korea and China, right, where they're even facing all this aging population, and obviously preventive measures are the key, the core priorities from the government. How are they innovating this space, to go from, all this annual or biannual screening into something that's more or better at early diagnosis and also, driving that prevention of all this NCD disease areas?
Yeah, thank you for that question. In fact, there are a few cases here, right? When it comes to cost, obviously the cost-benefit analysis has been done, and the activity-based costing, that's another one. You need to be able to do this cost-benefit analysis, you need data. So a lot of time, we don't track. So sometimes if you ask this question, how much does it cost a hospital to admit an emergency, right, the ED patient, right? We don't know, right? And if you don't know, then that is where, it's difficult to justify, especially when you want to innovate. Now, if you go along the line on the larger, you elevate yourself to another layer higher. Does it, to build a hospital, because this is something that we have been talking with the ex-DG, to build a new hospital, it costs a lot. I mean, it's not cheap to build a brick and mortar hospital together with all the, the GE equipment, the whatever Siemens equipment, and everything else. Can we not build more hospital, but use the Internet of Medical Device, right, the wearables, the point of care testing solution? Because these are the things that is already within Malaysia ground. You know that Malaysia has a very good semiconductor and electronics industry. We are the world leading. And we are actually very good in our fluid dynamics and the single chip, a lab in a single chip. So if we work along those lines, rather than build the brick and mortar hospital, which costs money as well, now you're actually moving into the new space that is innovative. And for your information, I actually has been studied this because healthcare is a universal right, right? So accessible to affordable, attainable, quality care for all. How do you achieve that? Right. The answer is through technology. So people, this is shared with me as well, one of the very prominent cardiologists from IJN. He said, in Kuala Lumpur, kita tengok traffic jam. In Sarawak, ada air tak sungai? Kalau tak ada air sungai, sungai tak ada air, you cannot come out to see the doctors, right? So in this case, affordable, attainable, quality care for all. If you think along those problem statement, that's where innovation comes in. I'm sure that, for those of you in this room, you know that MCMC has more than 900 pusat internet Malaysia in the rural pedalaman area, which has more than 45 megabit per second internet speed, good enough for you to deliver kiosks. the vital sign checking, and remote diagnostic and monitoring of those rural patients. So coming back to the cost now, if you were to do this, you need to have all those costing information. The answer at this point in time is we don't know, right? For the 52% that's coming from the public services, public health services, which provided by MOH, the 48% that comes from private, they know their cost very well. That's why if you go to the private hospital, they have EMR, they have all this X-ray. They no longer use X-ray. It's all electronics, DICOM file compatible, because they know how to do their costing. Right. So coming back to here, in short, the costing from the Western world, they are very good. They're almost like they can tell you, do how much it costs to do the scanning of this. And in fact, Australia, they actually distribute the cancer screening kit that they send to you. And you do everything, do the business, follow the instruction, and then within 2 weeks, you get the results. And that is a screening. And because they can put a disease cost, this NCD will cost the nation how much? By lost productivity, loss of this and that, and they are able to justify. Because if you were to say that we are going to send this cancer screening, colon cancer screening kit to all the 34 million Malaysian, what's going to happen? No way, because it's going to cost money. Right?
We need that data.
You need data. So in
So,
short,
I mean,
I think
when it comes to this sort of like use of data, drawing insights, and also coming up with more innovative ways to manage this, like, does it really drive like significant amount of productivity or efficiencies? Because if you look at some of the other industries, right, I mean, technologies often really drive, like what you said, 10 times, which is very likely, the 10 times in reducing costs or 10 times in increasing productivity. But in healthcare, is it realistic to see that sort of results? I mean, maybe it's a question to all three of you.
yeah, for me, definitely yes, right? When you do your lipid test, how long does it take for you to get your lipid test? You know the answer, right? Very fast. Yeah. Probably from a few hours, if you use the machine, right? It's just less than maybe 3 minutes. You get that. That is 10x, more than 10x, right? So if you want to get yourself, I think Professor Lee mentioned, the stethoscope. If I were to listen to my own heartbeat, within 20 seconds, I know whether I have AFib, whether I have all the condition or not. Without even moving an inch, I just have to sit there. I don't have to go to IJN and whatever. Isn't that the 10x reduction of cycle time? You spend 3 minutes rather than 3 hours just going to hospital. That's 10x. Right? So there is a justification on that.
I would just add on to that. Right now, the issue for a lot of us in the near future is not the ability of diagnosis, because there's a lot of work being put in. And as we have discussed, earlier diagnosis saves lives, saves costs, because then you can get earlier treatment. And the earlier you are treated, the longer you live. So technically, you save costs there, provided you're productive. If you're what we call in Ireland a langer, who doesn't work and who relies on social support, you're a complete useless item, but you're human. Okay, it's tough. It's not easy. Okay, but we heard about the last mile, and to me, what I feel is that we can have all this beautiful technology with AI-driven automation processes connecting healthcare to patients, early diagnosis, and so on and so forth. But the challenge here is that what do we do with that information? Because if you're diagnosed with a disease, you still have to come to the hospital to see a specialist. You still need to seek help. And a lot of the times, all our innovative solutions, AI-driven, are being picked up by many Malaysians who are already in that mood of seeking health. These are people who are already in a positive mindset. Their health-seeking behavior is already very high. But who do you want to impact? You want to impact those people who don't really care, who despite having an amputated leg and diabetes, still drinking that teh tarik nasi lemak. I'm really sorry, teh tarik nasi lemak, but it's the reality, right? That is a person that you really want to try and change the behavior. So now, we'll be moving not from innovation in technology to diagnose, but innovation in terms of how do we reach out to the patient so that they change. When you've mentioned is the uses of nudge. In health economics, we use a lot of nudge, behavioral things, and human tends to use nudge inadvertently. Dr. Koh had mentioned earlier on, the motorcycle at the Simpang part, he'll just go around in circles to get to the point the quickest way. He'll find the easiest way to get to his solution. And that's what we do with healthcare as well. We'll find the easiest way to get to our point, whether or not it's the right point, or whether or not we are swayed by Dr. Google or somebody else. There is also a red light along the way.
You know, sorry, just a couple of thoughts, right? I think we should not confuse innovation with high tech or AI all the time, because it's not. Especially in healthcare, it shouldn't be as well, right? We've had examples, right, where simple process re-engineering, simple nudges to the patient to have a better lifestyle, to go for screenings, to sort of have a more active lifestyle, can add up and have cumulative effects for the patient's health as well as for the entire ecosystem, right? So first, we are disconnecting innovation from high tech all the time. Having said that, right, we have entered into an era where the threshold of innovation has lowered quite a bit, right? You do not need the kind of resources you needed, let's say, 5 years ago to come up with cutting edge new applications. What you need is perhaps data, a lot of data, curated data. And then, you know, given the large language models, AI models which are available, you can innovate and come up with local applications. So the need of the hour is for local, in context innovation, whether it's low technology or high technology, and that definitely would get the 10x impact we talked about. Yeah.
Thank you. Thank you for sharing it.
So I think, frankly speaking, right, because healthcare is a highly regulated industry where the patient safety comes first, all the data, all the support has to be a trusted platform. Therefore, it's always good to go back to standards, right? Standards like, you know, even diagnostic standards, ICD-10, ICD-11, the fire, HL7 and so on. You need to start with those. Then, you know, you can actually have a ground to build trust. Otherwise, even you have a lot of data, people may question your data. Where did it come from?
I mean, maybe last few questions, given that we're about time, right? So, I mean, if you think about all this data-driven insight generation and strategizing based on that, I mean, it's a well-known fact. Like, I think we've seen this like 20, 30 years ago across many different industries. And even if you think about healthcare in some of the more mature markets, they have already started doing this. So why has Malaysia not achieved this level of stage where we have strong data to be able to then draw the meaningful insights to then innovate on our approach? Amrish?
So why doesn't Malaysia have it? I think data is there. It's just locked up in various systems. A simple example, I think it was highlighted earlier as well, right? There is no standard for EMR systems, right? Which means that patient data gets logged and siloed out across the various EMR operators or within hospitals, right? There are no standards which are defined for data interchange as well. Trust building on, public trust building on these data sources is also important, right? So I would actually contend that we do have the data. It's just that it is locked in. Second, I think it's also a matter of making sure that there is a local innovation ecosystem which is upskilled enough to unlock insights from this data, come up with solutions which can utilize this data, which has probably started in Malaysia, but that can be worked on.
Yeah, I think I was going to say that, you know, healthcare is very complex, right? Not only in Malaysia, everywhere else in the world, right, is having this problem. The reason is probably you can guess. In order to crack this problem, you need multidisciplinary team. In Prof. Adiba's term, co-creation. You need the engineers to work with the computer scientists, to work with the respective specialists. And most of the time, guess what? The medical doctors practice, they are very busy. They say, if I can't use this system in 2 seconds, I will drop it. So imagine, when you hear this type of comment, I'm sure many innovators out there, you know that if I cannot get this thing to work in 2 seconds, it's not going to work for me. Why? Because the doctors didn't come with the collaborative mindset. It's like, you need to serve me 2 seconds, right? Otherwise, not going to use it. So for this to work, you need to come with a collaborative platform whereby the scientists, right, the engineers, the medical doctors, clinicians, all have to work together with the mindset of providing a better care for everyone. And that's my take. Thank you.
Yeah, I totally agree with that. Trust is a big issue in Malaysia. We have lots of data, but we just don't trust giving it to other people. That's number one. Number two is that our ecosystem promotes collaboration to a certain degree, but in terms of the connection between the end user, like for me, I'm a clinician, so as you rightly say, if it increases my workload, I'm not going to use it at all. Like, guys, I hate your Fitbits and Apple Watch because it increases the number of patients that comes to see me with anxiety. So instead of being a cardiologist, I become a counselor. So that's what I'm saying. You have to be careful. But the collaboration really is where it has to be. In a lot of Western schools, and some in Malaysia, so I think Sunway has started, where they are introducing biomedical technologies in collaboration with medical students. So they would sit together and brainstorm ideas and come up with solution. It has happened in a lot of first world countries. We're still lacking behind, pretty much because of the structure of our curriculum. It's very strict. Trying to bend it, then you might have other issues coming in like MQA and stuff like that. So you just want to hold your breath and go blue.
Okay, I mean, we have maybe 30 seconds more, right? So maybe 10 seconds each. Maybe question for Professor Sursley. Maybe for Mr. Ambush first. What do you think the government or the private sector can do to accelerate the adoption of innovation? Because we know that there's a lot of creativity in Malaysia. So how do we then drive the adoption?
So I think at AstraZeneca, we've already we have a framework of identifying, scaling up, partnering with both private and public systems around innovative solutions, right? And I gave a couple of examples of AI, chest X-ray, and cardiac AI ultrasound, which are testimony to the fact that this framework works. So what we need is for the similar framework to be adopted by the government or the MOH and the governments. And then it sort of becomes disease area or solution agnostic, right? So that's, in summary, I think that is something where we have some experiences, we have many successes, and credit to MOH, we're already partnering with them. We're looking forward to scaling it up.
Thank you. And to Dr. Koh, what is the call for action for Malaysia?
I think, in my opinion, I'm still very much like Malaysia to grow in the innovation area. So first and foremost, follow the framework and standards that's already out there. You cannot circumnavigate around FDA and so on and so forth, right? So that's number one. Secondly is don't play in the field where the big boys are already playing, right? So HIS and all those, you can forget it. You can never outrun these people. So find a sidewinder approach, which means that you start with Internet of Medical Things or something that no one has ever done before, because actually we have strength. We have the electronics industry, we have the strength, right? So those are the area that in innovation, you look at the sidewinder strategy whereby just like China, electric car, they know they cannot compete in the combustion vehicle engines with the German, they move into electric vehicle, and that's what they are leading now. So in short, we should find our niche, play to our strength, and that's what I would encourage Malaysian to think along that direction. Thank you.
Thank you.
Yeah, I think we have to be smart about it. We have to be really smart. Breaking down walls, talking to engineers, to architects, to design experts, to automation, this kind of discussion, but amplified by 100 times across the country, across hospitals, across pharmacies, across all silos. And once you're able to breach that, then people are able to trust each other and communicate more freely, identifying pain points and creating solutions that will solve their pain point. Because at the end of the day, the end users will be in the healthcare sector, and we really have to answer and to address the pain points that they bring up.
Thank you. Thank you to all the panelists for all these very insightful answers. And I believe there will be a question from the audience, right?
All right, we do have one question, and the question is, what is best way to estimate the ROI from adopting specific technologies to meet the 10 times return?
ChatGPT is very clever nowadays, guys. You don't have to be asking us. You can put in all your basic costs, all your gaps, all the current costs of utilizing whatever technology, and you'll be able to see the output from there. I would advise you to do it. But I mean, on a health economics point of view, when we talk about return on investment and effectiveness, you need to also factor in the local population's ability to pay for those kind of things, the willingness to pay. And this is something that you have to do locally. You have to actually survey a few hundred people to ask, if I were to give you technology A, B, and C, how much are you willing to pay for this? Because then that will give you the appetite of the public to utilize that kind of solution. So we often use this approach for drugs, intervention, new drugs, for example, also for a certain solution like home care visits and stuff like that, and new technologies. So whether or not AI-based or innovation will be going down that way, maybe something to be seen.
To whoever is asking that question, right, apart from ChatGPT, do the math, right? If you notice, when the moderator mentioned the GDP, we spend how much? How many percent? 4-point-something%, right, of our GDP. You do the math, you know how much it costs, how much we spend. And from there, to tell you the truth, you know how big the market is. And the cost of ROI, you will get there. Do your mathematics. And you will, later you can let me know how much it costs. It's a very, very big number.
It's a huge number, I agree, but the huge number is only realized if it's a real innovation that solves a real problem. And that real problem will have to be rooted up from the very ground level.
You know the number, the GDP number, is how much we spend every year.
32 billion.
So I believe there are no other questions. Okay, then I think that's the end of the discussion today. So thank you so much to all the panelists. So just to kind of recap, I think, just to quickly recap, I think we understood that, look, there are some challenges ahead of us, in the healthcare. And obviously innovation is very well welcome, but we have to start from the basics to really understand what sort of problem that we're trying to solve for, whether we have the right level of data and insights to kind of build that. And we need a collaborative, co-creational effort in order for us to build something meaningful to improve the healthcare. So I know we are all healthcare professionals here, so we hope that we all collaborate, co-create, and let's make Malaysia better. Thank you, everyone.
All right, thank you to our moderator, Dr. Peter Kim, and to our esteemed panelists for the insightful and thought-provoking discussion on Malaysia's healthcare challenges. Can innovation save time, save costs, and save lives? We've heard how innovation, collaboration, and technology can work hand in hand to reshape Malaysia's healthcare system, making it more efficient, inclusive, and sustainable for the future. Thank you once again to our fellow speakers for sharing your valuable insight. And now, may I kindly invite our moderator and panelists to step forward to the center of the stage for a very quick photo session. Ladies and gentlemen, one more time, let's give them a huge round of applause. As usual, before we move to our last and final agenda, we'd love to hear your thoughts on our session. Again, we'll be showing you our QR code that is being displayed on the screen. So please take a moment to scan it and share your feedback through our short survey. Thank you.